We go on to the next speaker, Dr. Mohideen Abdul Kader, who is the Chief of Glaucoma Services at Advent Eye Care Services at Tirunelveli. And again, an expert glaucomatologist. And he's going to talk to us again on a very important topic, MIGS in primary angle closure disease. So on to you. Let's learn some more from you.
Thank you, Chitra. Yes, I'm audible.
Yes.
Yeah, it's going to be a mix in primary angle cluster disease. If you look at this, all the MIGS, I think suprachoroidal and subconjunctival are rolled out. Basically, you have GAT, you have tenotomacrocytic tuberculotomy, you have KDB, you have BAND, and GSM. These are few surgeries you can do it for MIGS, especially in angle cluster disease. At tenotomacrocytic tuberculotomy, tuberculotomy, you have two hooks, one is right, one is left, and used nicely for tuberculotomy, goniotomy, both nasal and temporal quadrant, and also a straight needle here. I'll just say a case scenario. This is doing a goniosynovitis to teneto in a post-acute attack of PACG.
Can you be louder?
Yeah. So this is in case of something is called phacoplasis in post-acute attack. 2 weeks post-acute attack, and pressure is very high, edema is there. I've done a phaco amplification first, and you have to be careful not to, when you do hydrodissection, not to be gentle. I've done a delineation first, then after that, because you can have somebody intraoperative high intraocular pressure. You have intraoperative glaucoma, then you do whatever you chop it off into multiple pieces, then you eat this meat like one by one. So once you finish this eating this phaco part, then you implant whatever lens you want. Then you take this, you put a nice coupling solution. I use a Swan Jacob lens. This is a teneto microphone. You see angles are totally closed. I'm trying this goniosynovitis. I'm just tapping this angle downwards. So once you see this goniosynovitis release, then I do a goniotomy. This is called tuberculotomy. You can do both right and left. I inflate my antechamber with viscoelastic. Then you look at my pigmented tuberculum myself. I just do a nice goniotomy or a tuberculotomy on one side. So once you finish, then also you can do on other side with another hook, micro hook. Then also you can do it on opposite side. So what happens that the processes are really controlled. But next comes the GAT. So GAT is the gonioscopic assisted transfer tuberculotomy. You have both eliminated catheter and also sutures. And what we use is all sutures because of economic way. I just give you a case scenario of GAT in PACG case. This is normally in a PACG, just phaco and goniocyclist may not achieve the intraocular pressure. You need to open this dispensational tubercular measure by doing a gap. So this is the case of a 52 years old female patient with OPD comes with a pressure of 44 to 56, and a point N cup in right and left eye, and you see the pass in all quadrant in left eye and pass in all except the creeping ankle in the right eye. I diagnose the PACG, and this is the field effect of this patient. I've done a YAG PA, reduce the pressure to 19 and 24 right and left is respectively, and this is the visual field of the patient. Left is more affected than right eye. And ask yourself, still want to do what you want to do. You want to do GAT or something else. So I done a GAT just in the case of I put again a coupling solution. I use a Swan Jacob lens. I keep my 5-0 which are ready for a GAT. And this is a totally closed angle. Can you believe this angle can be open like this? The first time I'm seeing so nicely angle can be totally synovial can be released. I'm really stunned to see this can happen in angles of glaucoma. So once this angle process is released, then you inflate this angle with again 1.6% sodium hydrogenate. Then the things become easy. Then I use 25 as needed to make a goniotomy. I just make an incision and into the pigmented tuberculum measure. So once you make this goniotomy incision, I use a 26 gauge needle. Then I make this incision. I just dip this goniotomy on. Then you see a OHS canal, slums canal, the void open now. Then I put my mushroom teeth 50 prolium. So once you put this prolium, then it goes, it just be going. Sometimes it has some resistance after 180 degree. So what forces we use, the vascular forces, what the retina is used for ILM peeling. Then you go smoothly, and also you make this your antechamber is fully inflated. Don't make it shallow. Then you just go little after 180 degree or 270 degree, you have some resistance. Push it little more harder, then you will get the suture from other side. then when you look at the suture from other side, just grab it off. Then you're happy, and you can just waiting for suture to come out. So once you know this going to come out, then then pull the suture from other side and pull it off. So then you do complete just pushing, because there's some resistance are there by pushing and just removing the last part of the sutures. So this is taken out and then just repeat off. This is really is an excellent result of this again PACG. And this is the case on the left eye. Left eye is a creeping angle close. See, one eye is open, one eye is closed. I'm just opening to the creeping angle closer, which is on the inferior side. I'm just doing it with a 10 microphone. So once this is open, then you make a routine, then you inflate the anterior chamber with the viscoelastic with 1.6% sodium hyaluronic. Then you're ready with your goniotomy incision. You just make an anterior to the pigmental tubercle measure. So once you make it, that incision, that goniotomy for 2 o'clock hours, you depress the incision. I use a 26 needle to do a goniotomy. You depress the incision to your slumps canal. So you can just see nice visible slumps canal. Then you just put a routine, your blended 504 mushroom sutures to do a computer gap. So look at the pressure of a pressure of 44 comes to 10 at the 6 month, a pressure of 56 comes to 10 at the 10 at the 6 month, the 20 pilocar and the bazolamide. And typically I use steroids for 4 weeks, antibody for a week, NSAID for 2 months, and pilocarpine I use it for regularly twice a day, especially for ankylosing glaucoma. The first 10 days with a head elevation, take rest, no straining, 2 pillows. You have to sleep opposite the surgical side. And this is a surprise to see our thesis was accepted as the best thesis. The outcome of FACO-GAD versus FACO-tuberculosis in a PAC in Indian population. Look at the complication rate. I have 20 years of tuberculosis. I have so much of complication. I have 1 to 2 years of GAD. I have only less complication. I think this definitely says we think the ankylosing glaucoma is difficult to GAD, but the excellent surgical result with it. See the
Doctor, 1 minute more.
Yeah. Look at the IOP control. The FACO-GAD is around 6.91% in the 6-month follow-up. There is 12.4% in the FACO cases. So excellent IOP reduction. I think the major, what the Shika was saying, the major obstruction, especially in ankylosing glaucoma, is the tubercular measure. Once you go past the tubercular measure, the distal outflow system is very good, especially in the ankylosing glaucoma. Slumps canal, culture, active vein, episcleral intact. Then your IOP, we have very good results in PACG cases. And hyphema is a big part, especially in a gap, as our Arthur was saying. I just show you some of the tips what I used to do. Keep the OT table a little higher, the reversible position, and help to prevent the blood reflex. And always you make an incision anti to the goniotomy incision anti the pigmental tubercular muscle. And pre of gonio diagram is very important. And this is the tip. And I make a small mushroom tip of your polonium. Don't make it very big, and especially for ankylosing glaucoma. And hyphema, keep the IOP more than 10, especially day 1. So less chances of hyphema. You keep the most perspective more than 10. And this is the technique what I just learned, what Askar was saying. I just make the wash this after GAD. Then I use my adrenaline just to an anterior chamber. Then I use my air tamponade. Then I fill with the 1.6% sodium hyaluronic. So what I do, I just wait for 10 to 15 minutes. If you don't want to wait, you can go do another case and come back, do a FACO and come back. And I use 1.6% to fill the anterior chamber, leave it for 10 to 15 minutes. Then I go back and then come back again, wash again this viscoelastic. Then I put little bit of air bubble. Then I hydrate my whole of the wound. Then I use 1.4% sodium around the air bubble. I leave it around 30 to 30%. This way, our hyphema rate is the MOXIE. This way, our hyphema rate has come down dramatically, especially in a gap cases. These are the instrument I use. Swan Jacob lenses, I use the polyene. I use 1.6%. I use 20 needle. I could last 3 forces, viscose over the complete solution, low power artery, and chronic can also end your blade if you don't not comfortable with the needle. And luckily, I met this 2 gentlemen, 2 big bands, Gaber, Grover, and Feldman. I'm very happy to meet them last in the ACRF, and they gave me a wonderful book for me, the presentation. And I just found until and the book is given is the first GAD done in 2011, and they are 2 years follow, and they are processed 10 and down without any medication. And he says, unless we have cure for glaucoma, we remain preparatory students as our patients are best teachers. This is our 1 year follow-up of GAT, especially in PACG. The pressure of 40 and 50. This girl came with the pressure of 40, 50. And we did a successful GAT, a process around less than 15 with one AGM. So in conclusion of all AGM, I think MIGS with GSL compared with GAT seems to be a promising initial choice in the PACG. It's good success with high safety percent in our population. I feel that the most common complication, if you use my technique, that will come down. And the intraocular floppy iris is one challenging eye faces, especially in the floppy iris. And GAT which is covered 360 degree images with no extra card. I think happy patients, happy surgeons. Thank you.
Thank you. Thank you. That was truly wonderful talk, Dr. Mohideen. So there is one question which I have for the expert panel here. Would you ever want to do MIGS as a standalone procedure, or would you always combine it with a cataract surgery?
I think yes, for angle-percent glaucoma, I think they will remove the lens. Then you get a better area to do again. Don't do fake it. To do something.
So yes, any question? Any of the expert panel, any question? Murli?
Yeah, I have a question. That is in patients with creeping angle closure. So you have done a goniolysis and you have also done the gap. So have you noticed in the post-operative period that the angle tends to, start closing all over again?
Yeah, we'll be doing pilocar most probably for longer duration. We don't stop pilocar. And so far, whatever we done for 1 year, 1.5 years, we didn't have any problem. I think high femur is the only one problem. Because high femur sometimes that coronary cleft can close. But I think if you done a good surgery, I think I'm much happier. Like for 20 years of struggling with all the PSAG, at least now I can take off I can get a bit cooler. I can give glass pieces much earlier. I can see them after 2 months, after 1 visit. Otherwise, very difficult sleep for angular glaucoma. What are the good surgeries you do in the post of all the complications, especially it is much higher, much happier, like less complication.
How do you choose between doing a 360-degree gap vis-a-vis a more limited goniotomy like a tornado hook or a bang?
I think my idea is to do 360-degree first. If I'm not able to do it, then I will do my tenator will be my next option. If I'm not able to do it.
Dr. Sushmita, your thoughts?
I would do a bang with any patient with glaucoma who requires cataract surgery. So that has become our standard of care now. 2 medications come down to 1 goes down to 0. So we do a bang, we don't do a GAT in the first. And I agree with Mohideen that PACG, of course, does very well. And those who are doing it, we now realize that GSL with a MIGS. So GSL bang is our go-to procedure along with the FECO. But interestingly, and I've said this before, that we found more peripheral anterior synechiae, as Murli was saying, because of pilocarpine. And I think it's because you move the lens iris diaphragm anteriorly in a raw area. And those were the patients who had more. So we actually have stopped using pilocarpine post-operatively. We use it intra-op, of course, but we stopped using it post-operatively. And actually, at the end of surgery, I put a drop of homatropine. And it keeps the lens iris diaphragm posterior in the rawest period of time. And I think that it doesn't dilate so much, but I think the ciliary, the cycloplegia helps both in inflammation as well as keeping. These are just preliminary thoughts. I don't have an RCT, but I was looking at gonioscopy after 4 weeks or 6 weeks, and invariably my GATs had a lot of synechiae. And then I stopped using pilocarpine, and it's better. So that's just one thought to take home.
How would you counter that, Dr. Mohideen, because you want to use it pilocarpine lifelong?
My patients are 6%, and you're happy. Because there is a pilocar. Some of the things, the AC is very quiet. I never seen an AC so quiet like a factor trouble.
Yeah.
Factor trouble, lot of turbulence. But they don't believe. This is a case of a nurse I done, first case. I can never believe you can do so much a good synechialis. I never believe you can do so good GAT in a PACG. I never believe I have to sold down. So what the thesis is, I'm the only surgeon. There's a double mask. I never know what the IOP pre, IOP post. I know the pre, but post I never know. Because even by my resident, I should be surprised to see so good IOP control. Believe me, less complication.
I agree.
Less complication.
And of course, the caveat is we always have to answer the question as to how do you know the cataract extraction is not working and your bang is. So we really, really need an RCT of the same kind of patients because my resident was in fact yesterday only mailing that we have so many now, and we can do historical controls of only phaco versus phaco bang or phaco gat or whatever. And I said, that will be completely biased, because my decision to do a bang is always according to that particular patient. And if I have a very large lens vault and just a 0.5 cup and one medication, I might do a phaco alone. What we need is an RCT of the same kind of patients, and then do only phaco in one and phaco bang or gat in the other, and then we'll have the answer.
Thank you.